Welcome to video 2 in our series of videos as part of this smooth muscle lesson. In this video we're going to talk a little bit more about excitation, contraction, coupling, and smooth muscle in quite a bit more detail. We'll talk a little bit about how the autonomic nervous system acts on this muscle. Let's start with the sort of the action potential. The smooth muscle cells generally have less negative resting potentials. So in cardiac muscle, the resting potential was about -90. More typically in smooth muscle, it's about -50 to -70 millivolts, okay? Down around in this range. Single unit skeletal muscle, again, electrically coupled by gap junctions, which are much less common in multi-unit muscle. And single unit, in theory, all your smooth muscles sort of acting together. That connection from gap junctions allows your action potential to propagate from cell to cell, so it acts as a functional syncytium. Multi-unit muscle, fewer gap junctions, so less so, more independent units operating. Single unit smooth muscle does not always generate spontaneous action potentials, but many types do. And when they do, they act a little bit like the SA node in that respect, where you've got an area of the tissue which generates the action potentials, which cause the entire tissue to contract. And that's exactly what I said here. All right. So we have a couple different general ways that electrical activity can cause contraction. Let's talk about two particular ones in first, general categories. First, we have some tissues that can have pacemaker activity. So this is very, very much like the way that the SA node works in the heart, okay? The membrane potential spontaneously generates action potential and changes. So the first thing you'll notice is your quote resting potential. It's not really resting. They call it phase 4 of the action potential. It's gradually rising here, and you get this gradually rising phase due to changes in membrane permeability that are really allowing positive charge to come into the cell and making the inside of that cell membrane positive relative to the outside, and making that voltage become less negative, okay? When the threshold is released, that is a certain voltage in the tissue where an action potential can be generated, is called a threshold. When it's released, you generate a full action potential. Your voltage shoots up, hits a peak, and comes back down. And when it comes down, it hits the bottom, and then you gradually increase the voltage again and depolarize the membrane, and it starts all over again until you hit threshold again and you throw another action potential. So you can see how this would generate sort of rhythmic activity. Slow wave potentials are a little different. They're alternating increases and decreases in voltage, okay? And they're usually due to cyclic changes in the rate of transport, typically sodium, across the membrane. Sometimes those slow waves don't reach threshold and don't throw action potentials, okay? They just go up and down underneath the threshold potential. And then sometimes they do hit threshold potential. Depending upon how the magnitude of these waves is modulated in the tissue. And when they do throw action potentials, okay? And you can see that here's a burst of action potentials, and typically the more action potentials you have, the stronger your smooth muscle contraction will be. Smooth muscle cells contain voltage-sensitive calcium channels that will open. In response to these action potentials, calcium will flow in, and that will cause the smooth muscle cell to contract, okay? And do note, because you can get the idea, particularly since we did cardiac muscle first, action potentials are not always required to generate contraction in smooth muscle. I'm going to show you that in a moment. But this is not really necessarily necessary for the contraction to happen. okay? And in fact, contraction can happen in the absence of an increase in calcium altogether. So here are 4 kinds of smooth muscle where you're getting a contractile response, an increase in force F, in response to a change, often in response to a change, in the voltage across the cell membrane, okay? Or at least that voltage is shown to correlate with the response. So here's our 4 ways. In A, we have triggered action potentials, sort of like the pacemaker activity that I showed you in the previous figure. And these open voltage-sensitive calcium channels, which means calcium comes in and causes an increase in force. And a lot of times what you'll see with action potentials like this, the more frequently the action potentials that are generated, the more force you'll generate. So here's an increase in force and then a relaxation in response to a single action potential. In smooth muscle and in skeletal muscle, what you can do is you can throw repeated action potentials, which will cause more and more force to be generated because you're not allowing that muscle to relax. The next action potential will cause more force. The next one will cause more force. There's no time for relaxation to take place. Note that this does not happen in cardiac muscle. Cardiac muscle always relaxes because the action potential is so long that you can't generate another one. The muscle always has a chance to relax before another action potential can be generated, okay? But that's not true in smooth muscle. You can get summation and an increase here. So the more frequent the action potential, the more the increase in force, okay? In B, we have sort of the slow wave action potential where you actually get firing of action potentials. And when you get the action potential firing here, you get your increase in force, right? And note the more action potentials you fire, the more force you get. And we have more frequent action potentials here, mostly because you're getting more of an increase in voltage. And the higher the voltage goes up, the more you fire your action potentials, okay? And the more increase in force that you get, all right? So that's another way to increase the force. You can get an increase in force with no action potentials at all. Here we have our membrane voltage going up, and the higher the voltage, the more calcium channels you open, for instance, and the more voltage-gated calcium channels you open, and the more calcium comes in, and the more force you generate. Less membrane voltage means fewer calcium channels open, meaning less calcium and less force, okay? So that can also happen in certain types of smooth muscle as well, where you get no action potentials at all, and the change in voltage causes the change in force without them. And then here, in D, we have an example of a response that takes place with no change in voltage across the membrane at all. The voltage is completely constant, and what you're typically doing here is you're binding a hormone or a neurotransmitter or a drug, and that drug is causing the force of contraction to increase independent of the voltage across the membrane. And this is typically true of pharmacomechanical coupling, where the changes in tension development are changed because second messengers are generated in the cell, and those second messengers have an effect upon the myofilaments in such a way that you get a contraction independent of any changes in voltage across the membrane. Okay, and this is particularly true of your autonomic responses, which we're going to go through really right now. So here we have factors that modify the activity of smooth muscle. The autonomic neurotransmitters we're really going to concentrate in terms of the physiology upon. Smooth muscle typically receives innervation from both sympathetic and parasympathetic branches. Generally, that's true. The arteriolar smooth muscle only has sympathetic, but most smooth muscle gets both, okay? We're used to thinking of nerves acting upon muscle like skeletal muscle, where a nerve will come in and it'll interface with the muscle at a neuromuscular junction and cause that muscle to contract. The autonomic nervous system works differently. The autonomic nervous system has one single nerve that will innervate many fibers through many different release terminals called in what are called varicosities. Okay, so the nerve kind of comes close to the cell, usually about a micron or so, and it'll release its neurotransmitter. And what will happen is that neurotransmitter will be released, and it'll diffuse all over the cell. Okay, so you have receptors everywhere in the cells here, and you have diffusion of this neurotransmitter along from these release terminals all along the smooth muscle membrane, and where it'll bind to receptors and cause a response. Okay, so your norepinephrine, your acetylcholine released from these varicosities, and binding all over the surface of smooth muscle. And by the way, this is what happens in cardiac muscle as well. Okay. You will note for single unit, we have one varicosity here, and note that our neurotransmitter is diffusing all over through multiple cells and multiple sections. And so it's almost like a local hormonal release more than anything else, where you've got the channels, or the receptors distributed all over the place. The multi-unit, kind of the same way. Your smooth muscle cells aren't contracted, but notice that you can get diffusion of this hormone from one varicosity, which is very close to this unit, to the next unit as well. So almost like a local hormonal release. Not necessarily localized to one unit of a multi-unit smooth muscle. Okay, the transmitter can diffuse to neighboring units as well. These are what the varicosities look like as they're strung over cells here, and you can see they're sort of like a string of nerve terminals that are releasing neurotransmitter. Same thing here. We've got our varicosities distributed over the smooth muscle cells that you see here, all right? Releasing our neurotransmitter, really acting more like a local hormonal release, okay? So, one aspect of the autonomic nervous system activation, binding to beta-2 adrenergic receptors, okay? So beta-2 receptors are different from the beta-1 receptors that we saw from the heart, but they act the same way, okay? They act by activating adenylyl cyclase. Increased adenylyl cyclase generates more cyclic AMP. Cyclic AMP activates PKA, okay? That happens in smooth muscle as well, where PKA is activated, okay? But the difference is, and what you should recognize, is that you've got different targets. This is the cardiac muscle cell. PKA has these targets. Active PKA has different targets in smooth muscle. So this is going to be typical of the autonomic nervous system, where a different receptor subtype will generate the same second messengers in the cells where that receptor is located. But the key to recognizing what that receptor is going to do in any given tissue is recognizing what the targets are for whatever that second messenger system is. So in this case, PKA isn't acting on these things, it's acting on myosin light chain kinase. And what happens is PKA phosphorylates myosin light chain kinase. And when myosin light chain kinase is phosphorylated, its activity is decreased, okay? And so ordinarily myosin light chain kinase phosphorylates myosin and causes contraction. When myosin light chain kinase itself is phosphorylated by PKA, its activity goes down. You have more inactive myosin light chain kinase, you have less active myosin light chain kinase, you have less phosphorylation of myosin, and therefore you have a relaxation, okay? And that is typical of the beta-adrenergic response in smooth muscle, a relaxation response, okay? So note that that's different from cardiac muscle, where these targets are different, and where you get an increase in the force of contraction. In a typical smooth muscle cell, the response will be to decrease force of contraction, okay? And that has consequences when you give a drug that binds beta-adrenergic receptors, because you have to know what it's going to do in different tissues, okay? But the second messenger system is the same, okay? So we have alpha-2 adrenergic receptors, and these actually act sort of like what the parasympathetic nervous system did. What they do is they decrease activity of adenylyl cyclase. They decrease cyclic AMP. They decrease activity of PKA. So this part of the chain is the same in smooth muscle, but the target for PKA is different. It's myosin light chain kinase. And if you decrease PKA activity, you will decrease phosphorylation of myosin light chain kinase. Decreased phosphorylation of myosin light chain kinase means you have more active myosin light chain kinase and less inactive myosin light chain kinase. More active myosin light chain kinase means more phosphorylation of myosin, and therefore you get a contractile response to alpha-2 adrenergic receptors. So they use the same second messenger system as the M2 receptors in cardiac muscle, in that they decrease adenylyl cyclase, decrease cyclic AMP, decrease PKA, but the effect will be different because the target is different in smooth muscle. In this case, you're getting an increase in force of contraction. When we did the parasympathetic nervous system, we got a decreased force of contraction because we were decreasing that cyclic AMP. And because the PKA had different targets. Okay? Notice that this response and the beta-adrenergic response on the last slide does not require a change in calcium. Calcium is still there, it's still binding to calmodulin, it's still binding to myosin light chain kinase, but this change in the activity of the myosin light chain kinase is independent of that. You can have the same calcium as normal, and when you alter this myosin light chain kinase, you'll alter the phosphorylation of the myosin, and you'll alter the contractile state of the smooth muscle. All right. Alpha-1 adrenergic receptors generate IP3. IP3 causes calcium release from the SR. We'll go over this in greater detail when we do the autonomic nervous system lesson, but calcium release from the SR means more calcium in the smooth muscle. More calcium in the smooth muscle means more calcium binding to calmodulin. More calcium calmodulin means more active myosin light chain kinase. More active myosin light chain kinase means more phosphorylation of myosin and more contraction. Okay? Alpha-1 adrenergic receptors. So these have a different second messenger system, but if you remember the second messenger system and you remember generation of IP3 and increased calcium, you can make predictions about what this receptor is going to do in different tissues, because you know that calcium, all you have to do is know what an increase in calcium does in the cell, and that'll tell you what the response will be. All right, other factors include hormones, various hormones, which we'll go over the course of the block when we run into them. Mechanical stretch, where that's relevant, we'll go over it. Local metabolites are relevant to arteriolar smooth muscle, so we will be talking about that in the next video in some detail. Drugs, of course, will be this is very relevant to the drug response, the pharmacology part of the vital fluids course. Okay? These factors typically act by changing the permeability to calcium at the surface membrane. More calcium coming in will increase calcium, or they will act by increasing calcium release from the SR, like the alpha-1 adrenergic receptors will do. So anything that binds to that receptor will increase calcium release from the SR, and that will cause you to contract more. Okay? All right. That's all I've got for this video. In the next video, we'll go over arteriolar smooth muscle as a typical example of how smooth muscle works, and of course it's a particularly relevant example for the vital fluids block. Thank you for your attention.